Hello, I'm Deanne Wright, a board member and co-chair of the Research Committee for the Scleroderma Research Foundation. Today, we have the great pleasure to have with us Dr. Ami Shah, whose talk is titled Scleroderma and Cancer, Implications for Cancer Screening and Therapy. Dr. Shah is a professor of medicine and director of the Division of Rheumatology at Johns Hopkins University. She is also the co-director of the Johns Hopkins Scleroderma Center. She's a graduate of MIT and the Johns Hopkins University School of Medicine. She completed her internal medicine residency at Stanford, her rheumatology postdoctoral fellowship at Johns Hopkins, and her Master's of Health Science in Clinical Investigation at Johns Hopkins Bloomberg School of Public Health. Dr. Shah's clinical practice is focused on the broad spectrum of patients with scleroderma, Raynaud's phenomenon, and the related fibrosing disorders. Her research has focused on the link between cancer and autoimmunity in the rheumatic diseases, as well as developing personalized medicine strategies in scleroderma with a focus on early detection of cardiopulmonary complications. She has received numerous awards, including the Henry Kunkel Young Investigator Award from the American College of Rheumatology. Thank you so very much for being with us today, Dr. Shah. And now I will turn the session over to you to tell us about scleroderma and cancer.
Hello, thanks so much for the invitation to talk about scleroderma and cancer today. My objectives are to review data suggesting a biological link between cancer and the development of scleroderma in some patients. I'll talk through implications this may have for how we should approach cancer screening in patients with scleroderma, particularly those with new scleroderma, and then briefly discuss some challenges that may occur during cancer care in patients with scleroderma. So first, what's known about cancer and scleroderma? There have been several studies that have suggested that patients with scleroderma have an increased risk of cancer compared to that expected in the general population, with most studies suggesting a 1.5 or twofold increased risk. We can see a wide array of cancer types, but lung cancer and breast cancer are the ones most commonly observed in patients with scleroderma. And interestingly, it's been observed that in a subset of patients with the disease, cancer and scleroderma can emerge together in time, and that's raised a question of whether there could be a biological link between the two diseases. There are several potential links between cancer and scleroderma, but I just wanted to talk through one potential hypothesis or theory, which is that our immune system has several different jobs. In addition to fighting infections, our immune systems are on the lookout for cells that are changing and developing into cancer. When there are cancerous cells, the immune system comes in to do its job, and there are several potential outcomes from that process. The immune system could succeed in fighting off and eliminating a developing cancer. The cancer could change and evolve and still escape the immune response and emerge clinically. This is what we see when someone is diagnosed with cancer. And in a subset of patients, either one of those possibilities could occur, but the immune response, in addition to fighting off a cancer, can begin to attack a patient's own tissues, resulting in an autoimmune disease like scleroderma. So we were interested in studying this hypothesis, and we recruited scleroderma patients who had cancer to look at this issue of timing. And so what I'm showing you in this graph is how long patients had scleroderma when they were diagnosed with cancer. And time 0 here is the time of scleroderma onset. And we looked at this time interval across different autoantibody subsets of the disease and identified that patients with RNA polymerase III antibodies had this tight clustering of cancer with the first clinical signs of scleroderma. This was very different than what we saw for patients with SCL70 antibodies and those with anti-centromere antibodies. And subsequently, several international scleroderma groups have confirmed this uniquely high risk of cancer around the time of scleroderma onset in patients with RNA polymerase III antibodies. We were interested in studying these patients' cancer tissues to better understand why this co-occurrence of the two diseases could be occurring. And so what I'm showing you here is a representative sample from a scleroderma patient with RNA polymerase III antibodies who had ovarian cancer and one who had breast cancer. And what we did is we looked within the cancerous tissues to see if this protein, RNA polymerase III, that's being targeted by the immune response, to see if it's being highly expressed in these patients' cancers. And what this brown staining shows is that indeed there's high expression of these proteins in the cancerous tissues, which was not seen in normal tissues, but also not seen in cancers from scleroderma patients with other autoantibodies. In subsequent studies, we investigated this further and found that the genes that are encoding this RNA polymerase III protein are mutated in tumors from patients with this autoantibody, and that the immune response that's developing is targeting both the mutated and normal form of the RNA polymerase III protein. So this suggests that cancer and the resulting immune response may result in the development of scleroderma. So the question is, if cancer could be a trigger for scleroderma in distinct subsets of the disease, how should we actually screen for cancer in patients with new onset scleroderma? And could we use autoantibodies as tools for cancer risk stratification? And lastly, if cancer is a potential trigger for scleroderma, could cancer therapy actually be effective scleroderma therapy? And this latter question really stems from several case reports that have been published in the literature where a patient may have cancer and scleroderma emerge together in time, and treatment of the cancer resulted in dramatic improvement in the scleroderma. So I wanted to share an example of a case where this intriguing question was raised of whether cancer therapy could be effective scleroderma therapy. This was the case of a 43-year-old woman who had diffuse scleroderma and polymyositis, and she had evidence of antibodies to this protein called PMSCL. And when this patient was diagnosed with new scleroderma, she was found to have a pancreatic mass. And when they resected that mass and looked in the patient's tumor, they saw that this PMSCL protein that she was mounting an immune response to, this protein was highly expressed in the tumor. Interestingly, in this case, when the tumor was surgically removed, the patient was able to be rapidly weaned off of all immunosuppression, given that she had resolution of skin thickening and myositis. So a really interesting case suggesting that cancer therapy in this case could have resulted in improvement of scleroderma. So this work raises several clinically important questions, and one of these is, who is at risk for cancer? When are they at risk? And for what types of tumors? To do this study, we partnered with individuals at the Johns Hopkins Whiting School of Engineering to look at cancer incidence in the Johns Hopkins Scleroderma Center cohort, and we compared this to a U.S. cancer registry known as the SEER Cancer Registry. And here we examined whether cancer risk overall and for specific cancer sites differs by filters that we think are important in this relationship. And that is the type of autoantibody a patient makes, the type of skin thickening they have, diffuse or limited, and this issue of timing around scleroderma onset. For this study, we included over 2,300 scleroderma patients who had a total of 205 cancers. And what we found is that within 3 years of scleroderma onset, patients with diffuse scleroderma had an increased risk of cancer compared to what you would expect in the general population when you adjust for things like age, sex, and race. We saw that there was a 1.5-fold increased risk of cancer. And among patients with RNA polymerase III antibodies, this was a 2.8-fold increased risk of cancer within 3 years of scleroderma onset. Among patients with RNA polymerase III antibodies, the types of cancers that they were at risk for differed by their clinical expression of the disease. So patients with RNA polymerase III antibodies and diffuse scleroderma had a high risk of breast cancer, prostate cancer, and tongue cancer, whereas those with RNA polymerase III antibodies and limited scleroderma had an increased risk of lung cancer. So it will be important to validate these findings in other scleroderma cohorts, but these data suggested to us that the type of autoantibody a patient has and their skin type may help us define subgroups who are at high risk or low risk for cancer in scleroderma. There are several unanswered questions that are active areas of research within the field, including, could we screen patients with scleroderma for cancer by blood tests, including autoantibodies, tumor markers, or even circulating tumor DNA? Could we screen by special clinical features of a patient's scleroderma or using novel imaging techniques? And importantly, could scleroderma get better when we treat cancer and when we use cancer treatments, even if a patient does not have a cancer that's clinically detected? So these are areas of active research. Now you may ask, what does this mean for me as a patient with scleroderma in terms of the best way to screen for an underlying cancer? And I wanted to start out by acknowledging that there are very little data looking on cancer screening strategies in patients with scleroderma, but it's clear that age, sex, and risk factor-based cancer screening is very important. And the use of intensive cancer screening strategies in patients who are at higher risk is an area of active research. So I wanted to talk through how I think about cancer screening in a patient who has a new diagnosis of scleroderma. I'm often doing a comprehensive history and physical exam and probing the family history to see if there's a family history of cancer. I think about performing a colonoscopy in my patients who are 45 years or older based off of screening recommendations in the general population. And while those general population recommendations are to stop colon cancer screening at the age of 75, if a patient has new scleroderma that's developed beyond the age of 75, I recommend a colonoscopy. Sometimes if a patient is reluctant to have a colonoscopy, then we think about looking at a stool sample for blood testing and doing a sigmoidoscopy or a stool DNA test, but colonoscopy is preferred. And I also talk with my patients about quitting smoking if they're actively smoking and use of sunscreen to prevent skin cancer. For women, I recommend a screening mammography at diagnosis and annually if they're above the age of 40. And I will note that in some of our U.S. guidelines for the general population, the recommendation is for mammograms to be performed every other year. But I think in patients with scleroderma, given the signals that we have for breast cancer, it's appropriate to do annual mammography. I recommend pap smears every 3 years in women ages 21 to 65. And again, for those who have HPV testing, that interval could be lengthened to every 5 years. In the general population, it's recommended to stop pap smears for cervical cancer screening at the age of 65. But if a patient has new onset scleroderma beyond this age, I do recommend updating the pap smear once to make sure we're not missing anything. It's important to update the gynecologic and pelvic exam at diagnosis. And then in selected patients who may be at higher risk for ovarian cancer, either because they had a personal history of early breast cancer or a strong family history, I recommend a pelvic ultrasound to look at the ovaries. In men, it's important to examine the prostate with a digital rectal exam. And while in the general population, there's some controversy about prostate-specific antigen or PSA testing, I do discuss the risks and benefits of this testing with my patients and often recommend that we obtain this test. And then in younger men, it's important to think about testicular examination, given the age at which patients are typically at risk for testicular cancer. I then think about unique risk factors that a patient may have. For patients who have a history of extensive smoking, I'm often recommending a low-dose chest CT, although often in patients with new onset scleroderma, we're getting a high-resolution chest CT scan to look for interstitial lung disease already. For a patient who has overlap autoimmune liver disease like primary biliary cholangitis, the recommendation is to obtain a liver ultrasound and a blood tumor marker called an AFP. And for scleroderma patients who have difficulty with swallowing and uncontrolled reflux, we consider getting an upper endoscopy for further evaluation. In addition, if that swallowing difficulty is not otherwise explained by GI disease or weakness of the muscles that are involved in swallowing, then it's important to think about seeing an otolaryngologist or an ENT for examination of the base of the tongue to make sure we're not missing a head and neck cancer. And in patients with extensive sun exposure and atypical skin lesions, it's important that they see dermatology for a comprehensive skin examination. I then think about unique risk factors that a patient may have that may place them at higher risk for cancer. And in this category, I include patients who have RNA polymerase III antibodies, those who are newly developing scleroderma above the age of 60, patients who may have aggressive, atypical, or treatment-unresponsive scleroderma, those with profound weight loss, or patients with a personal or striking family history of cancer. And in these patients, I think there's an open question of whether there should be enhanced cancer screening strategies, but often I'm considering whether to extend CT imaging beyond the chest, which again, we would be obtaining to look for interstitial lung disease, to also include the abdomen and pelvis, and referral to ENT for examination of the tongue and base of the tongue. In terms of active areas of research, we are studying the value and utility of whole body PET-CT scanning, breast MRI in women, and tumor markers, including liquid biopsies as early cancer detection strategies. So stay tuned for these results. In the last portion of this talk, I wanted to talk about some therapies that are used to treat cancer and some open questions in the field of whether it's safe to use these therapies in patients with scleroderma. The first area is radiation therapy. It's well known that radiation can trigger scar tissue formation in patients who are undergoing therapy for their cancer. And there has been a concern that in patients with scleroderma, that scar tissue formation or fibrosis could be exaggerated, and there's been a fear that scleroderma itself could flare. And as a result, radiation oncologists are often reluctant to treat patients with scleroderma based on isolated case reports published in the literature that have reported issues with scar tissue formation. The second area of cancer therapy where there are open questions is the use of these drugs called immune checkpoint inhibitors. These are drugs that activate the immune system to fight cancer, and commonly complications can develop from these therapies called immune-related adverse events, or IRAEs. And as a result, there's been a concern that patients with autoimmune disease could have a higher risk of developing these immune-related adverse events, or that their underlying autoimmune disease could flare. And so the initial clinical trials of these drugs excluded patients who had pre-existing autoimmune disease. So to study these questions further, we performed 3 studies that I wanted to share with you. The first was looking at scleroderma patients with breast cancer who were seen at the Johns Hopkins and University of Pittsburgh Scleroderma Centers. We had 116 patients with breast cancer at Johns Hopkins and 37 at Pittsburgh, 43 and 26 of whom were treated with radiation therapy for their breast cancer. And in this study, we observed that up to 50% of patients developed localized skin thickening in the field of radiation, but the risks of this developing did not differ by the type of scleroderma a patient had, diffuse versus limited, the type of autoantibody they had, or whether they were early or late in their scleroderma. Importantly, we did not see any flares of scleroderma in terms of exaggerated skin fibrosis or lung fibrosis, comparing patients who got radiation therapy for their cancer versus those who did not. In the second study, we focused on head and neck cancers because there's been concern that exaggerated fibrosis in the neck could compromise other structures in that area and affect swallowing and breathing as well. So in this study, we had 13 patients who had head and neck cancer who were treated with radiation therapy. 9 of the 13 patients did develop localized skin thickening in their neck, and about half of patients had a reduction in the range of motion of their neck because of the skin thickening. With head and neck cancer, it's common to have a feeding tube placed around the time of cancer therapy, and 2 of our patients did require that this feeding tube remain in for a longer period of time. However, no patients required any type of respiratory support. Importantly, from a scleroderma standpoint, we did not see any evidence of progression of a patient's interstitial lung disease, and only one patient out of 13 had skin progression beyond the field of radiation, but this was a patient who was in the very early phase of scleroderma where that type of progression was expected. We did try in some of these patients to use preventative strategies to prevent radiation fibrosis based on literature in the radiation oncology world, where they often use pentoxifylline, vitamin E, and amifostine. And in a handful of patients who did have fibrosis develop in their neck, we did use IVIG, which we sometimes use to treat scleroderma, to mitigate this. So these are areas of active study that require further investigation. Lastly, with respect to immune checkpoint inhibitors, we recently published our experience of 8 scleroderma patients being treated for their cancers with immune checkpoint inhibitors. 7 of these patients had long-standing limited scleroderma, and 1 patient was exposed to immune checkpoint inhibitors before they were diagnosed with diffuse scleroderma. In this study, we observed that 3 of the 8 patients developed a total of 5 immune-related adverse events. These affected the colon, the mucosa, the skin, the lung, and the kidney. Importantly, we did not see flares of scleroderma in patients with limited scleroderma. And in the 1 patient who had undiagnosed diffuse scleroderma, this patient did have progressive skin involvement, and in the setting of receiving corticosteroids, did develop a scleroderma renal crisis. When their kidney was biopsied, there was also evidence of this immune-related adverse event called acute interstitial nephritis. So in conclusion, with radiation therapy, localized skin thickening may be seen in patients with scleroderma who receive radiation therapy, but thus far we do not see compelling data to suggest that the scleroderma itself flares with respect to skin or lung disease. And for immune checkpoint inhibitors, we did not see any evidence of scleroderma flares in patients who had long-standing limited scleroderma. I think the risks in patients with early diffuse scleroderma require further study. And importantly, in patients who have interstitial lung disease, it's important to partner closely with one's rheumatologist for close PFT and chest CT monitoring. But my conclusion from our early experience is that scleroderma is not an absolute contraindication to these therapies. And it's really important to consider multidisciplinary decision-making that factors in a patient's scleroderma activity, a patient's own preferences and tolerance for risk, and alternative cancer treatment options that may or may not be available. This may be a good indication to see a scleroderma specialty center for an opinion as well. So in summary, subgroups of scleroderma patients may have a higher risk of cancer around the time scleroderma develops. Age, sex, and risk factor-based cancer screening is very important. Radiation therapy and cancer immunotherapy are not contraindicated in scleroderma, but careful multidisciplinary and individualized medical decision-making are required. And with that, I just wanted to acknowledge that the work I shared today was the work of many people at Johns Hopkins, and I wanted to give a special thanks to the patients of the Johns Hopkins Scleroderma Center for being our partners in these scientific discoveries. Thank you.
Thank you so very much, Dr. Shah. That was a fantastic talk and had a lot of really important information for patients in it. The Q&A is open, so submit your questions if you have them. And I'm going to start with a question. So I understand you to say that you have a really specific focus on the anti-RNA polymerase III autoantibody subgroup of scleroderma patients because to do cancer screening right away at the time of diagnosis. Is that also true for subgroups that have other autoantibodies? And how do you think about the timing of screening for different subgroups?
Yeah, thank you so much, Deanne. So we have seen that there are some other immune responses that can associate with a high risk of cancer around the time that scleroderma is developing. We've observed this for a less common autoantibody called RNPC3, or also known as U11, U12 RNP. And we've also seen this in patients who have Rho52 antibodies when they're negative for other tested autoantibodies. So we think that there are subgroups of patients where there is this increased risk around the time of scleroderma onset. The findings are most striking, though, for patients with RNA polymerase III antibodies, and that's been shown in many cohorts of scleroderma patients internationally. So based off of that, we do have increased attention to that subgroup of patients.
Okay, thank you. Am I understanding correctly that so far you've studied patients with POL3 and whether they're limited or to diffuse disease and potentially some of these other groups? Are you studying sort of the whole panoply of autoantibody groups, and would you expect to potentially see different cancers associated with those subgroups?
Yeah, so we've actually studied a group of 13 scleroderma autoantibodies to date, and we've looked at whether those antibodies individually associate with a high risk of cancer, whether that's around the time of disease onset or throughout the entire course of scleroderma, but also whether certain combinations of autoantibodies associate with cancer risk or cancer protection. And so far, the data suggests that if you have multiple scleroderma autoantibodies, that may associate with a lower risk of cancer, and that there may be specific combinations of immune responses that are cancer protective. In terms of getting down to specific tumor types, that gets harder when the antibody frequency is lower. So some antibodies are much less common than others, but we're still actively exploring that.
Okay, great. Thank you. I have a quick question on the finding of tongue cancer associated with RNA polymerase III autoantibody positive patients. Is that an HPV-related phenomenon? And do you find other head and neck cancers in that group?
We have seen other head and neck cancers in that group, but the finding is most striking for tongue cancer, particularly cancers at the base of the tongue, and those usually are HPV positive.
Okay, great. Thank you. So I want to focus a little bit on the really super impressive and thorough analysis you gave about how to think about screening, and how to focus it on age, sex, and risk factors. But not everybody is treated at a center like Hopkins. So what can you tell us about, for people who are treated at community facilities or not in large academic centers, what can you tell us about how those patients should be thinking about and talking to their physicians about cancer screening?
Yeah, I think one of the challenges when somebody has a rheumatic disease, be it scleroderma or otherwise, often the routine health maintenance things can fall by the wayside. So I think it's really important to engage in that conversation with your primary care doctor to make sure that those things that are due for everybody of a given age and sex are being performed. There are some nuances to that, I would say, in patients with scleroderma. So given the signal for breast cancer in patients with scleroderma, I would recommend that mammography be done every year, for instance, as compared to every other year. But there are guidelines out from the United States Preventative Services Task Force and the American Cancer Society that are guidelines for cancer screening based off of age and sex and certain risk factors. So it's important to kind of bring up that conversation with the primary care doctor and say, hey, am I due for any of these things, just to initiate that conversation.
I think that's really, really great advice. And how would you think about your advice on lung screening as well?
Yeah, so for patients who have new onset scleroderma, typically we're getting a high resolution chest CT scan to look for interstitial lung disease anyway. So I think that's an important part of scleroderma care and also helps us to look and make sure we're not missing an underlying lung cancer. In terms of later lung cancer development, I think it depends upon specific risk factors. So if a patient has an extensive smoking history, it is important to continue to monitor that over time. And in patients with interstitial lung disease, they may also need a follow-up CT scan. And I think there's some controversy in the field in terms of how often that should be done, because We always want to minimize radiation exposure to our patients through scans, but at least every few years, getting a follow-up scan, not only to look at lung disease progression, but also to make sure that we're not missing a lung cancer that's developed can be helpful.
That's great. That's great advice. You also mentioned a really interesting analysis you did on the safety of radiation therapy and checkpoint inhibitor therapy in scleroderma. Are you looking at the safety of other other more standard types of cancer therapies? And have any of them been found to be protective at all?
Yeah, that's a really great question. So in terms of the safety of certain chemotherapeutic agents, there are some drugs that associate with a higher risk of fibrosis or scar tissue formation, and other ones that work by inhibiting blood vessels. And so you can imagine how in Raynaud's that could potentially exacerbate Raynaud's phenomenon. That's been studied at the level of case reports, really published in the literature, showing a higher risk of these complications, but it hasn't been studied systematically as of yet. And we are exploring whether certain cancer therapies can be effective scleroderma therapies, so more to come on that.
Great. Well, thank you so very much. This was such a great session, and I think the information is so important to for every patient to have. So we really, really appreciate your time.
Thank you.